Good evening, everyone. Assalamu alaikum wa rahmatullah. It's me again, Usama Saleh from Dubai. It's our pleasure to welcome you today with our shoulder webinar. It's the webinar number 9th, which coming to you from the Dubai Shoulder Course Group in association with the Emirates Orthopaedic Group. Today, I have two eminent shoulder surgeons. One is a worldwide eminent coming from USA, Dr. JP Warner. Welcome, Dr. Warner, with us today.
Thank you.
Our second speaker is my friend Ali Maqdes. Welcome, Ali.
Thank you, Usama, very much for your nice introduction.
Thank you, Ali, for accepting our invitations. And thank you very much, Dr. Warner, for accepting our invitation. Today, our subject is the massive irreparable rotator cuff tear, which is a very interesting subject nowadays. And there is a lot of controversy and confusion among the orthopedic surgeons, the shoulder surgeon, of the best management plan for the massive irreparable cuff tear. And the decision making is very complicated as well. So we will hear from Dr. Warner today, which surgery for which patient, and how we select the proper surgery for each patient with a massive irreparable cuff tear. And Ali will give us tips and tricks and technical points on how to do lat dorsi transfer. So we will start first with Dr. JP Warner. Please, sir, go ahead.
So thank you very much. I'm a big fan of globalization of healthcare, and you just described my background, which is traveling around the world to become more knowledgeable. So I want to start by first providing credit to all my teachers and the people that educated and inspired me. I'm not going to be talking about how to do something. I'm going to be talking about why to do something and what you might do. And to that end, I present you a menu like you would have in a restaurant. This is called au contraire because so much of the thinking comes from France. And I won't talk about some of the things on the menu. For example, we won't talk about reverse prosthesis, but I'll talk a bit about the other things, and I'll do it from the standpoint of opinion versus evidence. And my perspective is about 30 years in practice now. In 1993, this is me as one of the two inaugural traveling fellows from the ASES to Europe. And I had already done my fellowship in Europe. And so let me give you a little bit of insight into my journey, because over the years, as you go along, let's see, why is that not going? My slide's not advancing. Oh, that's interesting. There we go. Over the years, as you age, you gain experience and scars, and they inform you what you might want to do and what you might not want to do. So that'll be the theme here. I have some conflicts of interest. The relevant ones are probably Orthospace, where I was the scientific advisor for this company, and then Stryker and DePuy, where I do consulting work, and probably the other ones don't really have any relevance. I also want to emphasize, for those who are interested, the Codman Shoulder Society is my newest venture, and it is a think tank. It's a global organization. It's free. Anybody who wants to join, just Google Codman Shoulder Society and you'll see how to join, because it considers a lot of the things I'll talk about, but also considers leadership, and it considers personal development and other things that are relevant to you as a surgeon. And it's predicated on Codman's ideas. And he was an entrepreneur. I mean, he was the first person to write a book in English about the shoulder. And one of his mottos was, give me something that is different for there's a chance of it being better. That's the definition of an entrepreneur. And then I blog on what I think is relevant to everybody. So you're all welcome if you wish. Now let's start with the experts. And some of you may recognize these individuals. Many of them are retired or deceased. And I think it begs the issue of how we learn what we do. As Franklin Delano Roosevelt said, there are as many opinions as there are experts. And I want to emphasize opinion, because a lot of what we do historically is based on the opinion of people we trust, not necessarily their evidence. And it was Gerber who coined the term, if two people agree, one is not a surgeon. And so we go to meetings to listen to people argue about their opinions rather than their evidence. But we'll consider this in this topic. Let's start with probably the most important shoulder surgeon of them all, and that's Charlie Neer, Do you know that Charlie Neer, when he conceived of anterior acromioplasty for impingement, believed that 98% of all rotator cuff tears were the result of compression of the acromia on the rotator cuff, and he was wrong. That was his eminence, and we all believed that for many years. We know now that that is not correct. Doesn't diminish him for other things, and frankly, if you look in Google about eminence versus evidence, you get almost 3 million results of articles trying to differentiate between the two. And a whole book by Mohit Bhandari on evidence-based orthopedics. And why do we have this problem? The problem is that when we innovate and create SCR or stem cell treatments or tendon transfers or reverse, we can either have a curve that goes up or a curve that goes up and down. And this is the diffusion of innovation. And if the curve goes up, there's a lot of money involved. So opinions become very emphatic. And remember, when someone raises their voice or argues, it means they have something at stake. So let's consider rotator cuff tear, first of all, from a market point of view. And this is old data, but 2 million visits to physicians annually in the United States, about 4.5 million per year, 400,000 surgeries per year. That's grown significantly more. And it used to be about $5 billion per year direct surgical costs. It's probably twice that now. Now, what's interesting is if you look at who provides surgery, this is a bar graph of the Mass General Hospital showing a total of 3,163 procedures performed, and each bar is a different surgeon. And look at the number of surgeries performed. Well, I think most of you would agree that experts live on the left side and non-experts live on the right side. So how can we judge who provides value is a very important point. And sometimes the literature will reflect what the non-experts are doing, not what the experts are doing. And it's important to remember when you read things, what exactly you're reading. This is an analysis of our ambulatory center, and what was very interesting to see, if we look at body part, the vast majority of surgery occurs in the hand. But when you look at the actual dollar value, as termed by RVUs, the vast majority of dollar value comes from the shoulder. Again, this is the focus we have in the economics of healthcare right now. At least in the United States, that's where the money lives. Now, this was an editorial that I wrote for a wonderful article in Arthroscopy some time ago, and Michael Porter helped with this. He's a professor at Harvard Business School. But the bottom line is that volume, the volume that you do, plays a role in determining outcomes and cost. That is that the value provided is directly associated with who's providing the service from the standpoint of their ability as an expert. Experts are less expensive than non-experts. So we have to remember this, because when a patient comes to see the doctor, whether they have a massive rotator cuff tear or not, they may see the primary care doctor and then they're distributed to maybe a specialist. That specialist could be a shoulder surgeon, a sports surgeon, or a hand surgeon. And the treatment algorithms define the resources used and the cost of care, and maybe the success or the failure of that care. And that may all be filtered into the articles we read. Now, popularity drives a lot of what we do, so let's consider the topic. Massive rotator cuff tear and irreparable tear constitute 377,000 and 82,000 searches in Google. What's fascinating to see is if you start to look at treatment, if you look at partial repair, you have 644,000 hits. And if you look at tendon transfer, 50,000, and superior capsular reconstruction, 365,000. What's fascinating for me to see is over a few years, if you look up the balloon that some of you may be familiar with, that's almost 9 million hits. So that's a very popular kind of fad right now with very little evidence, as we'll get to. Biological treatment, 1,400,000. Regenerative medicine, 27 million. And stem cell injections for shoulder pain, 21 million. And then advertisements and marketing is very important, whether you're using stem cell injections here. I don't really know what to make of that. Frankly, what's really interesting is here in Boston, we have the Boston Health Center advertising for these for your massive rotator cuff tear or whatever shoulder pain you have. And this is a really hot area, except this is interesting. In New York City, the Attorney General is suing all the stem cell centers for fraud. So clearly we don't have a lot of evidence. And frankly, if you dig through the literature, and this is the only slide I'm going to show of this, there's very, very little evidence as to the effectiveness of PRP or stem cells. And not to say it might not one day be effective, but most of what we have is animal data, not human data. and the hope that this could be something, because this is basically a generator. Now, let's get back to something relevant, which is clinical. Einstein said everything should be made as simple as possible, but not simpler. So if we talk about massive rotator cuff tear, let's ask questions. What does that diagnosis mean to you, and more importantly, your patient? Is it pain that they're coming to you for? Is it weakness? Is it because they've noticed some atrophy? This person has a massive rotator cuff tear and pain. This person plays tennis and has a massive rotator cuff tear. The size of the tear is exactly the same. The treatment is different. This patient has a massive rotator cuff tear, but as you see, he's got a belly press sign and a liftoff sign. Massive cuff tear, but different configuration, different treatment. This is a family of conditions, and knowing which member of the family you're dealing with is critical to individualize your care. So the things I know, and there'll be a lot I don't know, are this: that massive does not mean irreparable. Pathology matters as we define the tendon and the muscle, both. History matters because your patient's symptoms are what you're treating, and their comorbidities are part of the context. And then the clinical presentation matters. There's a big difference between weakness and pseudoparalysis. And I can tell you that surgeons, expert surgeons, don't agree on what each of these are. Well, if we look at size, for example, and for those of you who may be young, this is an open rotator cuff repair. That's not really done much anymore. But how was this defined historically? It was actually Harvard Ellman that defined it by tendon and by size, and ultimately Bob Cofield came up with a small, medium, large, and massive configuration, which has about the same relevance to biomechanics as Goldilocks and the Three Bears does, if you know that fairy tale. Christian Gerber looked at the results of massive rotator cuff tear, and he pointed out two important facts. Unfortunately, there's no universal agreement on the definition. And the second part is that it involves detachment of at least two tendons. So we should agree that a massive cuff tear means there are at least two tendons involved, not one. Actually, Colin did a study where he looked at the EFORT meeting, and he asked 15 surgeons to define how they say if a tendon is irreparable. What was interesting is that 11 of 15 defined it before surgery, but by different criteria. Humeral head superior migration, more than 3 tendons involved, or fatty atrophy, length of the tendon, lag signs, etc. 4 surgeons said, I don't define it until I actually do the surgery and see if I can fix it. Well, I wonder how many of you would pick which of these criteria as important in the way you define if a tendon is repairable or not. So I know this as well. Some operations fail before they start. So if I go to the operating room and I think I'm going to repair that tendon tear, that's not going to be successful. Or this tendon tear, that's not going to be successful. I don't need a classification to tell me that. Or this patient who has a subscapularis insufficiency after a Latarjet, I know that that's probably not going to be repairable. Why is this relevant? At the end of the day, someone has to pay for this. And when we do revision surgery, and you can see each of these is an operation at a different point in time with a number of failures going towards the right, the cost of care and the complications go way up the more revisions we do on a given patient. So what other factors are relevant? Age, social, emotional, workers' compensation, the pattern of weakness, is the patient stiff, the quality of the muscle and the tendon. It was Harriman and then Lichtenberg that pointed out that age is directly correlated to healing of the tendon after a repair. And it was Jungari that pointed out that fatty atrophy, as defined by Goutaillet, also affected this. And in fact, we should go back to Goutaillet, who is the father of muscle being the issue. And he wrote in his one of his original articles in the early 90s, it seems preferable to operate on wide tears, meaning massive tears, before they're irreparable, because irreparable means muscle damage has taken place. And I'm not going to go into the histology of this, which Christian Gerber won a Capodelto Award for, but most of you are probably familiar with Goutaillet's classification. And I would ask you, how many of you get an oblique sagittal plane MRI T1 weighted to look at the fatty muscle degeneration of the rotator cuff? This is critically important because it predicts elasticity of the tendon which you will repair. Now, Dominique Meyer and Christian Gerber took this one step further in this classic article, and they pointed out that stage 2 to 3 tendon tears with less than 15 millimeters of length of the tendon had a 92% likelihood of failure. So it's very important to understand these factors, and it's a much more powerful predictor than just Goutaillet grade alone. Here, for example, is the degree of retraction of the tendon and the odds ratio associated with its potential for repair. And here is a correlation to the fatty atrophy. If you have grade 3 or higher, there's a 100% re-tear rate, at least in Gerber's series. So that kind of is irreparable in my understanding. Now, it doesn't mean the patient can't raise their arm. It just means you're not going to fix it. Here's another case. This is a case from 1998 when I first came to Boston of a 30-year-old resident in orthopedics who was a rugby player who had a chronic subscapularis tear. Now, at that time, I wasn't as familiar with all of what we know now, but I can tell you that was irreparable. You know how I found that out? Because that's the tendon on the table. By the time I was done trying to mobilize it, there was nothing because the muscle had no elasticity and the tendon simply pulled out. And that was treated with a tendon transfer. But I could predict this now by doing the examination that points out the fact that his subscapularis is non-functional. That with the MRI would mean that I would not even try to repair that. Here's the problem. We also see patients that are weak and stiff. And so we have to differentiate these patients for their weakness from their passive loss of motion. This is a very important article by Walsh, the so-called dropping sign or hornblower sign or signe du clairon, which correlates the external rotation lag sign with an irreparable rotator cuff tear with a high degree of sensitivity. Again, we can know well in advance of the surgery if something's repairable. Then the patient may actually have tattooed on their body what they're going to be like. And this is a concept of Buzz Burkhead. It's sort of a joke, but it's somewhat true. If a teeth to tattoo ratio is less than 1, meaning there are more tattoos than teeth, then the patient's probably not a good candidate for any surgery. And if they have depression, chronic narcotics, history of smoking or work-related injury, and a massive rotator cuff tear, you probably are not going to fix their problem. Well, let's look for a minute at a 39-year-old man who has pseudoparalysis after a fall. If you look at this, he can barely raise his arm at all. Can you fix that and bring the humeral head down? Ask yourself that for a moment. I think we would all agree that that is probably a reasonable assessment that that's pseudoparalysis. And the answer is this is an acute injury, so you see he has excellent muscle. So in an acute injury, the answer is for sure, you can bring the humeral head back down and restore function. But this is not the same as when it's a chronic injury and becomes a muscle disease like we just talked about. So individualizing consideration as to the muscle tendon health is critically important when you decide what surgery you're going to do. If we look at this patient here, she's a 71-year-old woman with chronic pain, but she has excellent motion. But look at the size of her tear and her fatty atrophy. That won't be repairable, but guess what? It doesn't need any surgery at all. In fact, all she needs is therapy. And you can look around the world and find a number of studies that are prospective randomized in this area. This just had to be one from Finland that shows that randomization is to physiotherapy versus acromioplasty versus rotator cuff repair. At 1 year, all the groups are exactly the same. And so we know from the Moon group as well that physiotherapy for that kind of patient is appropriate, not a tendon transfer and not an SCR. Yet some of those patients might be in the studies we read, and we try to figure out the evidence in those studies. Here's a young Bassem El-Hassan when he was my fellow some years ago examining my patient, and you can see this patient who's a young man had an injury. He's weak, but he has excellent range of motion. I mean, how would you treat him? How many of you would try to repair his rotator cuff? Pretty good motion. He wants strength to do his job. Well, if we look at what we find when we do the surgery, we find a stiff tendon that can't be repaired. And so then ask yourself, is a partial repair going to be a solution? Or debridement, will that work? Well, you might remember Charlie Rockwood championed the concept of debridement. And in his original paper in 1995, he reported 83% satisfaction rate with the debridement. And Gilles Walsh added in the concept of biceps tenotomy and said, well, that's a great treatment. Here's a patient who can raise his arm. And it's interesting to me that Apoil, another Frenchman, in 1977 showed a high failure rate, but Rockwood and then Walsh said, you know, debridement, with or without a tenotomy, does well. But it was Buddy Savoie who won a Neer Award for following patients up to 6 years, showing a progressive decline in function with 8% satisfactory outcomes after 6 years, if you do that. So clearly that is not a durable method of treatment. Partial repair makes some sense, however, and the concept of Burkhardt here shows what a partial repair is in one of his original articles. What's fascinating to me is his functional improvement is exactly the same as what he reports with SCR. Take that for any way you want to take it. But there's another possibility here, and that's the concept of Carl Basmania, that when you do a partial repair, you take tension off the suprascapular nerve. And some of you may have seen this. It's another contested area, but if you pull the cuff laterally, you take tension off the suprascapular nerve as it's tethered around the base of the spine of the scapula in the suprascapular notch. And we were able to reverse neuropathy by doing that and published that in a small group. We looked in the lab, and if you can see here, red is a simulated massive cuff tear, and green is an intact cuff. And you can see how the tendon is pulled medially, and it might be, at least theoretically, possible that it's under tension and causes pain. So when you release the nerve, I think you'd all agree that this is an irreparable massive cuff tear. Now, you might be inclined to do an SCR in this setting or even a tendon transfer. And I think that's okay, except this patient had excellent range of motion and just pain. And the pain was over the top of the shoulder. So this is coming through the soft spot behind the clavicle. There's no supraspinatus in the fossa. That's the fossa. The first thing you see here is a suprascapular nerve. And if you think it looks like it's stuck in the bottom of the fossa, the muscle has pulled it medially and downward and tethered it. So whenever this patient moves the arm, this is like a cubital tunnel syndrome of the shoulder. And if I put a probe here, I can lift up on the nerve, and most of you might have the impression that that's inflamed, and it's stuck underneath the transverse scapular ligament, which in this instance may almost be like carpal tunnel release. And so if I use the technique I learned from Laurent Lafosse and do a release, I might be able to decompress the nerve so that it moves more freely. And for this particular patient, I didn't do a big operation. This is all I did. And this patient had dramatic relief of his pain without repair of his rotator cuff because he was well compensated biomechanically. And this at least seemed to be the mechanism that was causing his pain. You'll see in a minute here how the nerve moves. And I don't want to leave this topic without mentioning this. This is a rare situation, but one which does from time to time present when patients have pain over the top of the shoulder without cervical spine disease. And now you see the nerve is free to glide once we've done that. Now, what about pseudoparalysis? What is it? If you look at this patient here, she clearly has a lag sign with the arm at the side. Simply falls back down. And if we abduct the arm and externally rotate, the entire arm falls down. This is Walsh's drop arm sign or dropping arm sign. Now, for me, these patients are generally not good candidates for tendon transfer or SCR. They are really appropriate for a reverse prosthesis. This here is a patient who has weakness. He does not have pseudoparalysis, but he has pseudoparalysis as defined by Burkhardt, which is inability to raise the arm more than 90 degrees. For me, that's not really the definition of pseudoparalysis. Well, this is getting to the take-home point here. And the take-home point would be the relationship of massive chronic tears and the cuff tear pattern as described by Colin, which I think is a very, very logical approach that you should all consider. Now, if you look at a massive cuff tear, and red being the tear, you have type A through type E. And it's interesting that in the type A, they usually have good range of motion. They're compensated. And that is the same as well, typically for type C, and it may be for type D. It's type B and type E that are problematic with lag signs or pseudoparalysis. I'll come back to this in a minute, but this may inform the treatment you decide. So let's consider evidence now that we've looked at popularity. If you look at superior capsular reconstruction, the promise offered by Terahusu Mihara, who created this, and I might add, he did it with autograft fasciolata, not allograft. He demonstrated 83% healing and superior migration of the humeral head being reversed in his series. Oh, that's very encouraging. And frankly, SCR is here to stay. More than 20,000 cases last I looked at, probably 30,000 now. And these are the articles devoted to this in pubmed.org, but we'll come back to the articles in a minute because the quality is very important to consider. This is one such article where SCR improved function greater than 90%, pain as well, with a 12-month follow-up, a 1-year follow-up. Here's another article by Pat Denard and colleagues, 75% success, but 20% revision rate, okay? Do you really think that you can bring the humeral head back down with a static soft tissue placement on top of the shoulder. Maybe you can, maybe you can't. This is a very much debated topic. This is another more recent article, and more recent articles are coming questioning this. 36% re-tear rate, which correlated to fatty atrophy. The other articles didn't. In fact, they didn't suggest that that was important at all. But clearly, that may play a role here as well. And then our article, which looked at early experience, which probably reflected learning curves. And you could see the first 10 cases done by 5 surgeons had a 77% failure rate. And then the next 10 cases, we dropped it down to 42% failure rate. But still, at the end of the day, that was our experience. Now, maybe that just reflects how poor we are as surgeons, or the fact that we're not experts yet. But remember, I told you that at the beginning here. Consider the source. So it may well be that I'm comparing apples to oranges when we're looking at the outcome of experts who are doing this. Maqdes himself said most surgeons are on a learning curve, and variable outcomes are due to graft healing and surgeon skill. And Steve Burkhart talks about the burden of the craft. And I wouldn't argue with them because they're experts. The only thing I would say is ask yourself if you're an expert before you try that. Now, I just want to set up my co-speaker here who's going to talk more about latissimus transfer, but my first exposure to this was actually in the 80s when I visited Christian Gerber, and then I came back as a traveling fellow. And I learned about open tendon transfers, and I had my own learning curve problems with this. I was able to study this, and I won't dwell on it. There's many, many articles written on this that I'll go over in a moment. I can tell you that 81% successful outcome with a 10-year follow-up by Gerber's pretty good track record when you consider. Now we're, of course, doing these arthroscopically and comparing arthroscopic latissimus dorsi to arthroscopic lower trapezius to SCR. And what's really fascinating is if you start to look at outcomes using registries as we have, you find some interesting things. First of all, there is no question that arthroscopic latissimus dorsi or lower trapezius is less painful than open. That's clear for me anyway. It is also the case that at 1 year, at least for me, tendon transfer is superior to SCR for pain relief. Now, that may not be the case for others, but that's just our experience. And the same goes, at least there's a trend for more durable outcome in terms of function. Again, there's never been a prospective randomized heads-up comparison. But look at this patient here. It's a 48-year-old man with 9 failed prior surgeries. I think you would all agree with me this is pseudoparalysis. And the only reason he's not getting a reverse prosthesis is because he has an absolutely normal appearing joint and he wants to work and he's young. So he's got a lag sign in every position. In abduction, as you'll see here, he can't hold his arm if I lift it for him. He's flexible. And I really didn't expect that this would work, just given the magnitude of his weakness. But I wanted you to see here, this for me is not an SCR because I don't know how I restored dynamic stability. And if you look at him after, here he is now 8 months after.
And now down.
And you can see he has excellent flexion.
All the way up. And then out to the side like this.
And most importantly, functional external rotation.
Great.
And I don't know how to do this without doing a tendon transfer.
Rotate him out.
And again, you can see reasonable external rotation. We'll just show you here.
If I put your arm here, can you hold it here?
That it's not just passive.
Push out. Okay.
Okay.
I'm going to turn you this.
So I want to just finish up on some more innovative areas that may or may not be valid in the future. Some of you may have heard of this so-called balloon. I gave you my conflict of interest for this so you understand that there may be some opinion here. I do stand to benefit, but this has been used all over the world now and has just finished the level 1 study, which I helped put together for the FDA in this country. And anyway, I won't go through all the ways of how this is done, but the concept is that this has the same effect as an SCR by biomechanically stabilizing the humeral head, so it doesn't move superiorly. And George Athwal did a study biomechanically showing this. Here's a woman pre-op. Here she is 3 months after the placement of the balloon. And if we watch her over the coming several years, you might wonder, how is it that she can maintain this kind of function when the balloon itself dissolves and goes away? That's pretty impressive at 3 months. And in fact, here we are 18 months and there's no more implant in this patient. I would suggest that it probably conditions the remaining rotator cuff to function more effectively, but I can't tell you exactly how that happens. And if you look at the number of studies that have been done, and there are many data points on this, you can see the progressive growth of the improvement of the constant score over time. So what have you learned? I'm going to finish up here. And I think you've learned that evidence is generally outweighed by marketing. And there are fads out there and a great deal of attractiveness of new concepts because there's a lot at stake, economically and also egocentrically. If we look at all the articles out there that warrant an analysis, there are not that many for SCR. There are 3 times as many for tendon transfer. And it's not entirely clear for the balloon that there are sufficient to make any judgment. If you look at those articles that are positive versus negative, clearly most of these articles are positive. There's not a whole lot of negative written. It's hard to get that published. But ask yourself when you see these 2 patients here, if that was their problem before and that was his problem before, what would the treatment be? Would you be surprised to see that that's a balloon and that's a tendon transfer? Neither patient cares, although I can tell you the one on the left has a much faster recovery. So the final concept I want you to understand here is Scott's parabola. And that is that technology is introduced and it is encouraging. And there's enthusiasm for it. And the balloon's probably early on. And then there's some widespread enthusiasm and soft evidence, and that's probably the SCR. Then there's durable outcomes that have been demonstrated through scientific methodology. That's probably tendon transfer. I cannot tell you where SCR and balloon are going relative to the curve here. That remains to be seen, and you should consider that as you adopt these different forms of treatment. The final point I would make is this. Remember the classification I gave you? Your brain should be calculating which technique is best for my patient. This menu may change, but clearly certain approaches are better for certain patients depending on the pattern of their weakness, the magnitude of their weakness, and their functional deficit. And if you think this way, you'll probably solve each patient's problem, as you should, as an individual problem identified for that patient. And at the end of the day, the value you provide is very much on your decision making, and the execution is important, but the wrong decision means the execution doesn't matter. Thank you.
Thank you very much, Professor Warner, for this very nice presentation, very informative. I will move on with our next speaker, Dr. Ali Maqdesi. He will talk about, apart from the options of management of massive irreparable cuff tear, which is a tendon transfer, and he will talk specifically on lat dorsi transfer today. Ali, please, you can start.
Yep. I'm going to specifically talk about latissimus dorsi transfer, how to do it, and what to predict, and when to choose the right patient for such condition. Some of the disclosures that do not have any confounding factor with our talk today. So I'll go again about Dr. Warner's talk and repeat some of the things that I think that should be the things that you take home from today's webinar, is how to diagnose an irreparable tear and some of the available options, and then we'll go into the technique about the latissimus dorsi. Of course, irreparable tear is very hard to describe. Should you use classification in the frontal view? Should you use the Collin classification in the sagittal view? And I think it should be a combination of everything, and especially in a case like such. You don't want to go into the shoulder finding yourself with this kind of scenario. And I'm sure that even with the best hands in the world, it is very difficult to mobilize such an immobile tendon, such tendon that has no excursion, and of course, expect a bad recovery from such sort of thing. So the question is, when can we choose, and how do we decide beforehand what to do and when to do? Of course, I like to make my repairs just like the meat I eat. I like my red meat, very red, no fat. So I like to go with a grade 0 or grade 1 steak when I go to the restaurant. And the same goes for my repair. I don't like to go into grade 2s. I don't like to go into grade 3s. And of course, I hate to go into grade 4s. And I use the Gutalier classification or the Fuchs classification on the MRI to give me a good idea about that sort of thing. I am not the one to say, but this has been proven by multiple studies that fatty infiltration is a very bad prognostic factor for healing and for outcome. So the treatment options have been already proposed by Dr. Warner. I try to go very quickly about the first of the possible options that we can do today for such cases. In a case where you have an excellent range of motion with a painful shoulder, superiorly migrated shoulder, think about elements like stability and horizontal stability of the shoulder. Check that you have a good subscapularis in the front. Check that you have a good teres minor in the back. And if so, you would be stunned to find that then the range of motion is excellent. And in these cases, maybe a tenotomy or something to do with the biceps can help. A debridement or debridement can help. Maybe something like what Dr. Warner proposed for a suprascapular nerve release, even though I have little experience with that, but I'll try to think of that from the future and try to do an EMG for such patients and see if there's an element of compression on the suprascapular nerve. So if the shoulder is functioning very well and you've tried all your medical treatment, and of course you've failed the conservative treatment and all sorts of injections and rehab and all that, then this could be a small part of your treatment that is very simple with a fast recovery. Or you can go into something a little bit more sophisticated. If you think that you have a disruption of the cable, maybe your subscapularis has recently ruptured on an acute and chronic situation, or your infraspinatus is torn due to an acute injury, or it is no longer stable in the horizontal view, try thinking of doing a partial repair to repair either subscap, infraspinatus, teres minor, or sometimes with a sort of margin convergence to cover the head. Could be a good solution if you have not got the rest of the arsenal you've mastered the rest of the arsenal. Dr. Warner talked very clearly about this new technology and how we can maybe change our views in the next couple of years with the proof that will come very soon, how things do in the near future, like the balloon, the superior capsular reconstruction, and of course, the grafting of the cuff tear. I don't know any other solution if you have a pseudoparalytic shoulder in a chronic setting with such a shoulder in an older patient other than doing a reverse shoulder arthroplasty. This would move me next to my topic now. So a latissimus dorsi transfer is a transfer that has been proposed for patients with an irreparable posterior superior cuff tear, and now recently with other sorts like the subscapularis tear. For me, or in my hands, it has to be selected very well for it to work properly. For that to happen, we need to have certain things that should be available in our patient. And for me, these are the ideal indication or the ideal things that I should see in a patient who can receive a latissimus dorsi transfer with a predictable good result. He should have a painful shoulder that has resistant to all medical treatment. He should, in my view, even though others disagree, an intact subscapularis and not a repairable subscapularis. He should have a Hamada 2 or subacromial space of 3 to 5 millimeters with no evident glenohumeral osteoarthritis and no evident pseudoparalysis. For example, this is one of my patients, a 55-year-old male who's a right-hand dominant, right shoulder pain since 4 years, with a trauma 4 years ago due to a fall. He's an active guy, he likes to fish, and he does a lot of work at home and likes to do drilling and screwing or whatever is around the door. He's had 6 months of medical treatment, 3 subacromial injections, and a lot of physiotherapy. He's still very painful with a lot of night symptoms. When I examined him, this is what I got. He had an extremely good range of motion, full passive range of motion. There's positive signs of rotator cuff tear. There's no hornblower sign, and there's a slightly positive external rotation lag sign with a constant score that is not so bad and an SSV of 68. For me, after checking out his radiological aspect, this is what I see. I see a humeral head that's well centered. For me, a stage 2 to stage 3 tendon retracted supraspinatus infraspinatus with an intact subscapularis, and I could not find the sagittal Y view in T1, unfortunately, but he has some fatty infiltration in the infraspinatus and supraspinatus with not a lot of amyotrophy in the supraspinatus. That for me was an irreparable rotator cuff tear. I went about and did a surgery for this guy, but I chose to do a latissimus dorsi. And this is how I do it. So it's set up in the B chair position. I leave my hand free so that I can elevate the arm. I palpate the belly of the latissimus dorsi. I do about 10 centimeter incision, and I like to extend a little bit up into the axilla to help me identify the tendon of the latissimus dorsi. I try to nicely dissect the latissimus dorsi from the teres major at the back and at the front of the tendon. I check to locate the pedicle of the latissimus dorsi anteriorly. I then introduce some Homan retractors at the superior part of the wound on the humerus, internally rotate the arm and tenotomize the tendon as far as I can go. I like to have at least 8 centimeters of tendon. I do not use a bone chip. I whip stitch my tendon. I release my muscle down until I reach the scapular border. And then I prepare my way just between the posterior deltoid and the triceps muscle. After I have done that, I move back my arm into the traction and I go into the arthroscopic view. I explore the glenohumeral joint and of course, confirm my diagnosis. I always like to check my subscapularis tendon. And if I see that my subscapularis tendon is partially torn at the superior part, which is probably a Lafosse 1, I do not do anything for that. I always do something for the biceps tendon and then quickly move my scope to the lateral view. When I move my scope to the lateral view, I start dissecting the subacromial space to find my spine of the scapula. Sorry, I'm a bit ahead of the video. I'll just wait a couple of seconds to finish that part. Of course, I come back to the biceps later because I've done a tenodesis in this patient. So now I'm in the subacromial space. Sorry for the view. I could not get a better view. I fight always with my anesthesiologist, but they try to do their best. So we go and I dissect the subacromial space and try to identify in my first step the spine of the scapula, which you will see very soon coming up, which gives me a good landmark of where to go next. Okay, so you're starting to slowly identify the Gothic arc at the back of the shoulder. That means on the right is the supraspinatus and on the left is the infraspinatus. I then move to the left between the deltoid and the infraspinatus to move more posteriorly into the shoulder until I pass the infraspinatus and go down to the teres minor. At that time, then I try to identify two things. I try to identify the triangular space and the quadrilateral space. And to do that, I try to put in my mind the medial and the lateral part of the posterior shoulder. I try to avoid going laterally because I know that the axillary nerve is close by. So I always try to go into medially. I switch my working portal into the soft point and move more posteriorly into the shoulder until I identify the tendon of the triceps. Okay, so now you will see me slowly working that space at the back, going more laterally to identify the triangular space and the nerve. Of course, I don't try to play too much. See that the blood pressure is getting a little bit better. When I push my scope down into that space, I can see a little bit better. This tissue is very easy to dissect. You start to have a little bit of problem to triangulate your instrument at this point. It is normal because you are working at the same plane in a very closed aspect. I prefer to put my arm in slight internal rotation at this part to help open up the space, which could be a nice trick to help you expose better the posterior part. So here, medially, we can see that we are starting to identify maybe soon enough the triceps tendon, and you see as soon as I open up the space. And laterally, soon you will see me getting to find the nerve, the axillary nerve. So we know that that part should not be dissected more, or you should not go on. So you see laterally here, I see some crossing tissue, and here I stop going there, and I come back medially. And in a couple of seconds, you see the longitudinal fibers of the triceps tendon appearing, which concludes, in my point of view, the posterior dissection in the arthroscopic portal, in the arthroscopic time. I then introduce a suture retriever from my posterior portal, just following up the space. You see the triceps tendon showing up very nicely here on the right. It's the whitish longitudinal tissue, which will be more clear in a second or two. And then with the suture retriever, I try to reach from the top of the shoulder using the posterior approach into my axillary incision and retrieve the sutures that I've prepared for the latissimus dorsi. Okay, so I just skip forward this part. It's just a lot of dissection and okay. And then you see me retrieving my tendon now. So in this case, this was a couple of years ago. I used to tubulize the tendon. I no longer do this. I now like to keep it flat. And I've heard that using this fibrous tissue around the tendon would help its healing. I have stopped using that as it has expense. And you see on my tendon, I add some metallic sutures to help me identify my tendon on X-ray. So it's a very good tool. It takes just a second. You can do this while the tendon is outside the body. I use fixation with anchors anteriorly, which give me satisfactory fixation on the humeral head. It works when it's correctly indicated. And this is the proof. This is the same patient that I have operated a year and a half later. He has full range of motion. He's extremely happy. He's gone back to fishing, and he's telling me, when can we do the other shoulder? So he has the same condition on the other shoulder, but it's less painful. But because of the good result that he had on the right, he wants to go and do the left. So I think when you choose your patient correctly, you do get good results. This has been proven by all these colleagues, and one of them, Dr. Warner, who's done extremely good work on the latissimus dorsi. It has been proven long-term to give excellent results in terms of pain and maintenance of function. Unfortunately, do not propose it for somebody who is looking for strength. It has all concluded that it is a good surgery for pain relief. It gives better anterior flexion with a better external rotation, but no improvement in strength. If you compare surgery done in that aspect of latissimus dorsi transfer, and if you have the time to repair some of the tendons, especially at the back of the shoulder, add 1 or 2 sutures to the infraspinatus has been shown very well by my mentor, Philippe Valenti, that does give slight benefit over a normal latissimus dorsi. It takes maybe 10 or 15 minutes more to add 1 suture, 1 anchor to the infraspinatus and try to pull that up when you do your latissimus dorsi. The technique has been changed, or people have been proposing newer techniques now. Instead of doing a tubular tendon through the humerus, we moved on to a tubular tendon over the head of the humerus, pulled very much anteriorly. That was what I used to do a year or a year and a half ago. And now I follow what my friends or my colleagues are telling us, to put a flat tendon more posteriorly and not pull it so much anteriorly, to have less failure in the musculotendinous junction, as shown by John Canine. In cases that you do, for example, you have done this surgery and unfortunately has not worked, it has failed, it could happen, patient's not happy, you have not seen good results, or after a couple of years, you think that this patient is re-complaining of pain, you do not burn any bridges, and you still have a good result with a reverse shoulder arthroplasty with less or little risk of complication postoperatively. And we have done this study with Philippe Valenti to prove that. So for me, in conclusion, when to do a latissimus dorsi for posterior superior rotator cuff tear is when you have a patient with no pseudoparalysis, an irreparable posterior superior rotator cuff tear, with no superior migration or minimal superior migration, and for me, an intact subscapularis and not a repairable subscapularis. An arthroscopic assisted, for me, is better than an open, and if you are technically capable of doing a full arthroscopic latissimus dorsi transfer, good luck. I think it would be even better. If you can associate a partial repair, do it. Aim to have a flat tendon instead of a tubular tendon. Do not put it too much anteriorly. Keep it at the posterior superior part of the humeral head. And do not forget that you have not burned any bridges with this surgery and could always be converted or taken to the next level with a reverse shoulder arthroplasty with little or no side effects. Thank you very much.
Thank you very much, Ali, for this very informative presentation. Very well done.